we'll start with the topic of paranasal sinus first. Okay. Sinus which is not present at birth is maxillary sinus, ethmoid, frontal, or all of the above. Anybody, any guess on this? Sinus which is not present at birth is maxillary, ethmoid, frontal sinus. Which one is it? Answer is frontal sinus. At birth, only maxillary and ethmoid sinuses are present and are large enough and clinically significant are the maxillary and ethmoid sinuses which are present at birth, and frontal sinus and sphenoid sinus develops later. This is the table which summarizes the development of the paranasal sinuses, wherein you can see maxillary sinus and ethmoid sinus are present at birth, and the first radiological evidence is 4 to 5 months for maxillary sinus, and ethmoid sinus is 1 year, and the maxillary sinus reaches adult size by 15 years and ethmoid sinus reaches adult size by 12 years. Whereas sphenoid sinus, which is not present at birth, but radiological evidence is seen at 4 years and reaches adult size by 15 years. So frontal sinus, which is also not present at birth, but radiological evidence is seen at 6 years and reaches adult size by until teens. Okay, this summarizes the paranasal sinus development and their radiological occurrence and when they reach the adult size. Most superior sinus in the face. It is quite easy and you can make a guess of it. And the frontal sinus, ethmoid sinus, maxillary sinus and sphenoid sinus. What would be the correct answer? Most superior sinus in the face. It is frontal sinus. The most superior sinus is frontal sinus and most posterior sinus is sphenoid sinus. Largest sinus is maxillary sinus. These are the well-known facts and very easy to remember. And as you can see here, the frontal sinus is the most superior one and the most posterior one is the sphenoid and the largest one is the maxillary sinus. Most common paranasal sinus involved by fibrous dysplasia. As you know, fibrous dysplasia is a benign and it's a type of osteogenesis, defect in the osteogenesis, and most common paranasal sinus involved in fibrous dysplasia is maxillary sinus, frontal sinus, ethmoid sinus, sphenoid sinus. Any guess? Most common paranasal sinus involved by fibrous dysplasia is maxillary sinus, frontal sinus, ethmoid sinus, sphenoid sinus, out of which the answer is maxillary sinus. And the characteristic feature of the fibrous dysplasia radiologically is ground glass appearance of the maxillary sinus. The bony covering in the radiological bone in the radiological picture resembles ground glass appearance. That is, the glass, when you ground it, it becomes hazy. So both transparent and hazy. So that type of picture, ground glass appearance of the maxillary sinus, is seen in maxillary sinusitis like this. This is the OPG, orthopantomography, where you can see the ground glass appearance here. Compare to the other side. This is translucent almost. This side, normal side, is translucent, whereas this is ground glass appearance. The same thing here. It's a bigger picture. It's a water's view, and which shows the right side normal sinus, whereas the ground glass appearance of the maxillary sinus here, or frosted glass, or you can call frosted gas appearance in water's view. This is the maxillary sinus. Schuller's view and Lakh's view is for sphenoid sinus, mastoid air cells, foramen ovale and spinosum, carotid canal. Sphenoid sinus, mastoid air cells, foramen ovale and spinosum and carotid canal, Schiller's and Lach's view. Schiller's view and Lach's view is for sphenoid sinus, mastoid air cells, foramen ovale and spinosum or carotid canal. Which is the most probable answer? Any guess? Schiller's and Lach's. It's actually a very good question and easy also. Schiller's and Lach's view. It is B. Answer is B. Mastoid air cells. If you go into the detail, the Schiller's view is, as you know, Dr. Arthur Schiller, Austrian neuroradiologist, has explained about this. First explained about this view. X-ray beam is projected 30 degrees cephalocaudal to prevent superimposition of two sides of the mastoid bones. When you take X-rays like this, if you give at the 90 degrees, the mastoids, the diseased mastoid and normal mastoid, both may superimpose. That will not give you the correct view. So you must make 30 degrees angle so that one mastoid stays up and one mastoid stays down. Okay. Now structure CNR is external artery canal is superimposed against the internal artery canal of the other ear. Okay. Now mastoid air cells, tegment, lateral sinus plate, condyle of the mandible, synodual angle, eticoantral region. Key areas of cholesteatoma and erosion. You know what is the characteristic feature of cholesteatoma radiologically? Do you know? Bony erosion of cholesteatoma can erode any bone. The characteristic feature of cholesteatoma radiologically is what? It is the erosion of the scutum. Scutum is the outer etic wall. It is the characteristic feature of the cholesteatoma in radiologically, both in X-ray and CT scan. And in Schiller's view, you see all the views, all the structures, all the major structures of the mastoid and condyle of the mandible also. Synodural angle, which is useful when you are planning for mastoidectomy surgery, so that you know the extent of the posterior boundary of the mastoidectomy, where you can see the lateral sinus, where is the sigmoid sinus plate, so that you can take precautions beforehand. This is the 30 degrees angle of X-ray beam to be projected. And last view, it is lateral view of the mastoid, simply lateral view of the mastoid. Dr. Frederick Law has described this, and sagittal plane of the skull is parallel to the film. X-ray beam is projected at 15 degrees cephalocaudal. Most common site of osteomas among the paranasal sinuses is maxillary, frontal, ethmoid, sphenoid. Frontal. Next most common. Next most common. Okay, we have this is a simple straight bit. Most common site of osteomas among the paranasal sinuses: maxillary, frontal, ethmoid, sphenoidal. Frontal. So most of them have got correct answer, but we'll take a next step. That is, what is the next most common site of osteomas of the paranasal sinuses? Osteomas is a benign tumor. Ethmoid, you are right. Ethmoid. This is the osteoma, frontal sinus osteoma, CT scan of the frontal sinus showing the osteoma like this. Order of occurrence of osteomas is frontal, ethmoidal, maxillary. As I told you, sphenoid osteomas are very rare, and malignant tumors are more common in paranasal sinuses than benign. This thing you should remember. People working in wood industry are exposed to the increased risk of sarcoma of paranasal sinuses, squamous cell carcinoma of paranasal sinuses, osteomas, adenocarcinoma. B. Okay. Any other guess? Squamous cell carcinoma of paranasal sinuses, sarcoma, osteoma, adenocarcinoma. It is adenocarcinoma. It is adenocarcinoma. I will tell you about sarcoma, squamous cell carcinoma also. This is the wood industry. They are prone to adenocarcinoma. Adenocarcinoma, paranasal sinuses. A few words about it, and more common in hardwood furniture industries. And squamous cell carcinoma (PNS) is more common in people working in nickel industries, and it is also seen in cadmium industry also. Nickel and cadmium industries are more prone for squamous cell carcinoma, paranasal sinuses, and as such PNS cancers are more in leather industry and mustard gas manufacturing industries also. Most common histological type of PNS cancer is squamous cell. Next bit. Orbital cellulitis is most commonly occurs after which sinus infection? Maxillary, ethmoid, frontal, sphenoidal. Which is the most common? Orbital cellulitis most commonly occurs after which sinus infection? I think Sri has got right answer. It is C, ethmoidal. Simple logic of it is ethmoid sinus is very close to the orbit. It is divided, from the orbit. Ethmoidal sinus is divided by orbit by a thin lamina called lamina papyracea, which is a thin bone, which is not always continuous. It's like paper thin with defects in it. So ethmoid sinusitis, which is close to the orbit, causes the orbital cellulitis more than any other sinus, because maxillary sinus infraorbital rim is a strong bone compared to lamina papyracea, and therefore the correct answer would be ethmoid sinusitis, most commonly seen in children. When you see eye swelling like this and purulent nasal discharge, suspect acute ethmoiditis. This is what I have told you. The ethmoid sinuses are like this. These are the ethmoid sinuses, and they are close to the orbit, directly, almost close to the orbit. Therefore, in surgeries of the ethmoid, the orbital complications are more. This is the lamina papyracea, which I have told you. Mucocele is commonest in which among the following sinuses? Frontal, maxillary, ethmoid, sphenoid. Mucocele. There is a caveat in this question. Read the question properly. Mucocele is commonest in which? Mucocele is commonest in which among the following sinuses? Frontal, maxillary, ethmoid, sphenoid. Answer is A, frontal. Don't get confused with mucocele and mucosal polyp. Polyp is common in maxillary. Okay. Now, mucocele is commonest in which among the following sinuses? Maxillary, frontal, ethmoid, sphenoid. Mucocele is commonest in frontal sinus. This is the mucocele. Huge mucocele. Which of the following attains adult size before birth? Mastoid antrum, orbit, ear ossicles, cornea. No, mastoid antrum attains later to almost 12 to 15 years. Ear ossicles. That is the answer. It is D. Is C, sorry. The ear ossicles. Answer is the ear ossicles. And a brief thing to make you remember, by the 16th week of gestation, the ossicles reach adult size. Malleus, incus, stapes, everything. So including foot plate. So the mastoid bone not included in the mastoid process is almost adult size at the time of birth. Mastoid air cells development and nematization takes place primarily during the first 2 years of life. Okay. Mucormycosis of paranasal sinus is most common in HIV, diabetes, those on immunosuppressants, post-surgical. Diabetes. Why not immunosuppressants when the patient is on immunosuppressants? Diabetes, those on immunosuppressants, post-surgical. Why not HIV? But the answer is diabetes. In the textbook it is described as the mucormycosis is most commonly seen in diabetes, and also this is the mucosa, this is the black lesion of the mucormycosis, and this is the orbital complications of mucormycosis, and the appearance of mucor in right orbit, periorbital skin and maxillary sinus of 60-year-old man with diabetic ketoacidosis. This is the thing, and in book immunosuppressants also cause, but out of which the common is diabetes. So when both are given, go for the common things, and diabetes is the answer for mucormycosis. And another bit is A gamma globulinemia can present with rhinitis, bronchiectasis, giardia infections, all of the above. A gamma globulinemia can present with rhinitis, bronchiectasis, giardia infection, all of the above. Don't jump, think. Sri got it, even Pratik got it. All of the above. A gamma globulinemia can present with rhinitis, bronchiectasis, giardia infection, all of the above. And A gamma globulinemia or hypogamma globulinemia. A gamma is complete absent of gamma globulins, and hypo is less compared to normal. Most common of the primary immunodeficiencies. It is one of the most common of primary immunodeficiencies. The HIV everything is secondary immunodeficiencies. The gene responsible has been BTK, which stands for Bruton tyrosine kinase, and defective antibody production and low circulating number of B cells. These will cause the immune function of the mucosal membranes, causing the rhinitis, as I told you, rhinitis, bronchiectasis, and in the abdomen, giardia infections. All of the above. Answer is all of the above. In functional endoscopic sinus surgery, opening is made through first opening. Have you seen functional endoscopic surgery? I advise you to go to any site where functional endoscopic basic surgery is surgery, and the entry point of functional endoscopic sinus surgery is, let me put it this way to make things easier. Yes, osteometrial complex. So answer is B, osteometrial complex. Target of functional endoscopic sinus surgery is to preserve the function. It is self-explanatory. Functional endoscopic sinus surgery. The sinus surgery done by endoscope to preserve maximum function. That means preservation of the mucosa, preservation of the natural anatomy as far as possible. So this is the main aim of the functional endoscopic sinus surgery. When you preserve the natural anatomy as possible, as near possible to the nature, you and the mucosa, preserve the mucosa, the drainage of sinuses will be very easy. So functional endoscopic surgery is to facilitate natural drainage process. You are making a natural drainage process. You are facilitating it. Okay, you are not removing the natural drainage process or replacing it. Hirschman has first described the endoscope use in nose, and he has done with cystoscopes. Cystoscopes, you know, for the examination of the urinary bladder. So, in a modified cystoscope, a shorter version of the cystoscope is very long. So, a shorter version of it is described by Hirschman first, and then enlarge the tight passages in the osteometrial unit, including the natural osteomaxillary sinus. As you know, all the sinuses drain into the nose. Like maxillary sinus drain through the osteometrial complex, that is through the infundibulum, and the sphenoethmoidal recess has drainage from the sphenoid sinus and the posterior ethmoidal sinus, and the anterior ethmoid also drains into the osteometrial complex area, and these are the sinuses openings which you will get access by way of doing endoscopy and making the openings wider, preserving the mucosa. That is the basic aim of the functional endoscopic sinus surgery. That's what you are doing in functional endoscopic sinus surgery. Earlier, when endoscopes were not there, the functional endoscopic sinus surgery was not there. People used to do radical surgeries like cadval Lakh, opening the sinus, removing the mucosa, or frontal ethmoidectomy, or ethmoidectomy, or lateral ethmoidectomy. So these things are little bit radical, in the sense they destroy the function, they destroy the normal drainage pathways of the sinuses. The indications are a chronic sinusitis, expanding mucosal of the parental sinus, as we have seen in that bit where a frontal mucosal is there, and you can approach through the endoscope and make the frontonasal duct wider and drain the frontal mucosal. And nasal polyposis, resection of pituitary adenoma. This is an extended surgery where neurosurgery, it's a part of neurosurgery. It can be performed through the sphenoid sinus, where the basis sphenoid is identified and the cruciate incision is made after removing the posterior sphenoid wall, and then the pituitary adenoma can be taken out, scooped out. CSF leak repair. It is very easy when compared to the older days, where they have to open the skull by craniotomy and separate the brain from the layers of the this thing, identify the leak and then repair. It is mortality and morbidity are both high in those cases. Now it has become very easy with the endoscopes, where you can access the exact location of the CSF leak and plug it with the various materials like homologous fat or any autologous bone. Okay, now autologous fat, these things can be done. Foreign body removal, as you know, life becomes easy when you go near the foreign body and take it out, instead of doing the blind procedure in olden days. Contraindications: absence of osteometrial abnormalities, relative contraindication, and disease of lateral frontal sinus, where the frontal sinus extends almost up to the superior, lateral part of the eye, above the eye. Okay. Now the access to that area may be limited, but newer techniques have come wherein angled endoscopes can be used, and we can get into the lateral wall of the frontal sinus also, but little bit difficult. So in those cases you have to do open frontoethmoidectomy. And osteomyelitis of the frontal bone, meningitis or malignant pathology, because when you are opening the planes, the malignancy can spread very fast. So usually, and access to the malignant tumor is also very difficult with the functional endoscopic sinus surgery. Most feared complication of endoscopic sinus surgery is most feared. It is not most common. See the wordings. Most feared complication of endoscopic sinus surgery is retroorbital hematoma, CSF rhinorrhea, internal carotid injury, nasolacrimal duct injury. CSF rhinorrhea is relatively common complication. When you do ethmoidectomy and frontal sinus surgeries, CSF leak is can occur, quite common. Not quite common, but it can occur easily. Of course, nasolacrimal duct injury can occur, and retroorbital hematoma, it can occur, all can occur. Internal carotid injury can occur, but read the question carefully. Question is important here because all can occur. Shall I tell you? It is C, internal carotid artery injury. It is fatal. It can turn to be fatal. There are very few cases who have survived with internal carotid artery injury. When you are doing the posterior ethmoidectomy surgery, when you miss the extension of the ethmoid cell into the sinus, into the sphenoid sinus, or it can get injured when you don't identify the structures properly in the lateral wall of the sphenoid sinus. Okay. Now, internal carotid artery injury is the most feared complication, which can cause death of the patient also. Carotid artery injury during endonasal surgery is the most feared and catastrophic complication during sinus surgeries, including FES. Orbital complications are most feared over all complications of FES. ICA bleeding, internal carotid artery bleeding, is the most feared, most feared complication of FES and open sinus surgery. When the bit is given like that, you have to think which is very difficult to manage. It would be the correct answer. Internal carotid artery injury and retroorbital hematoma, both are most feared complications. But we can manage retroorbital hematoma comparatively easily than the internal carotid artery injury. Okay. Now, retroorbital hematoma is due to the anterior ethmoidal artery injury retracting into the orbit and then causing the continuous hemorrhage. Okay. Now, it can be managed by various ways, like redoing of surgery, opening the lamina, ethmoidectomy, doing ethmoidectomy, tracing the optic nerve, and then tracing the hematoma and evacuating the hematoma. That can be done. But internal carotid artery injury is very difficult to manage. So, out of all the four, internal carotid artery injury is the answer for this bit. FES surgery, structure preserved is ethmoidal sinus, sphenoid sinus, maxillary sinus. Simple. FES surgery, structure preserved is ethmoid sinus, sphenoid sinus, maxillary sinus. Maxillary sinus. Why do you say? One is access is not to all walls of the maxillary sinus are not removed. The FES is done for all the making all openings of the sinuses wide. That we call sphenoidotomy if it is sphenoid sinus opening. Maxillary sinus sinusotomy if you call maxillary sinus opening, and then ethmoidotomy if you open the ethmoid. But in some surgeries, ethmoid can be completely removed, need to be completely removed. Okay. Now, sphenoid sinus, when you are doing, as I told you, when you are doing when you want to do pituitary adenoma, you are removing one of the wall of the sphenoid sinus, and then ethmoid sinus, in as I told you, posterior ethmoid disease, you have to remove the anterior ethmoid. So, every sinus can be removed except maxillary sinus, where the walls are preserved. Walls and mucosa, everything is preserved by the functional and endoscopic sinus surgery. By that relativity, the answer would be maxillary sinus. Okay. Types of functional and endoscopic sinus surgery. There are 4 types. Okay, nasal endoscopy, uncinectomy with agar nasal cell exenteration. This is type 1. This is a basic one. Okay, making the doing uncinectomy and making the drainage pathway of the maxillary sinus, removing the obstruction to the drainage pathway of the maxillary sinus, and then type 2 is apart from type 1, bulla ethmoidectomy, that is the bulla is the largest ethmoid layer cell. We have to remove the ethmoidectomy, bulla ethmoidectomy, and removal of sinus lateralis and mucous membrane and exposure of frontal recess and frontal sinus, that is the frontal drainage pathway. Type 2, type 3 is type 2 plus maxillary sinus enterostomy through the natural sinus ostium. Type 3 is complete posterior ethmoidectomy combined with the type 1 to 3. Type 5 is sphenoidotomy and stripping of mucous membrane. All sinuses are seen in which view? All sinuses are seen in which view? Cadwals, Waters, Lakh, none of these. Have you seen any paranasal sinus X-ray? Then it's okay. Then which is the most common paranasal X-ray sinus taken in any general hospital or any hospital? Ma? What is it? Waters view. Answer would be Waters view. Waters view. Waters view. It is the 45-degree angulation is maintained, and this is the typical Waters view where you can see the frontal, ethmoidal, maxillary. Okay. So, and what is this? Yes, sphenoid, and it is taken open mouth. When it is taken open mouth, when you close the mouth, what happens? Bony overlap happens of the mandible, bony overlap happens, and you can't see the sphenoid sinus properly. This is the view of, this is the Waters view, and it can be almost all the sinuses are seen here. This is the Cadwell's view. Cadwell's view is 15 to 20 degrees tilt of the beam towards the radiographic plate, and where you can see the frontal sinus anatomy is seen better in Cadwell's view. Waters view is also called as occipito-mental. Cadwell, occipito-frontal. So you can remember like this: Cadwell view, occipito-frontal. So frontal sinus is better seen. Okay, occipito-mental, maxillary sinus is better seen. Waters view shows all sinuses except sphenoid sinus, which can be seen if Waters view is taken with mouth open. Pneumatization patterns of sphenoid are all except pre-sphenoid, post-sphenoidal, basis-sphenoid, conchal. Read the bit carefully and the options carefully. Before sphenoid, behind sphenoid, in front of sphenoid, behind sphenoid, under the sphenoid, or conchal. Pneumatization patterns, all except post-sphenoidal, all except post-sphenoidal. That is, behind sphenoid there won't be any pneumatization. Pneumatization patterns of sphenoid are all except pre-sphenoid, post-sphenoidal, basis-sphenoid, and conchal. This is the classification proposed by Congan. The pre-sphenoid, basis-sphenoid, conchal, and occipito-sphenoid. As you can see here, it is the conchal. Small pit, almost non-pneumatized. This is called conchal, and this is the pre-cellar. This is cella, and this is pre-cellar. Okay. Now it may be limited the entire sphenoid body. This entire sphenoid body is the sphenoid body. This is the cella, this sphenoid body. Very small limitation is conchal. Precellar, before cella is the anterior wall of the cella turcica, where it's called precellar, and behind the cella turcica also it extends behind the cella turcica also, that's called basisphenoid or cellar type. All drain into middle meatus except, this is almost easy, lacrimal duct, maxillary sinus, frontal ethmoidal sinus. A. All drain into middle meatus except, answer would be A. Why? Very good. Lacrimal duct. The acronym, the mnemonic is there, PS famine, where the drainage of nasal meatus is seen. That is posterior ethmoidal sphenoidal sinus drain into superior meatus. Drainage into middle meatus is by frontal sinus, anterior ethmoidal, middle ethmoidal, maxillary sinus. Drainage into inferior meatus is nasolacrimal duct. This is the diagrammatic representation where you can see semiluta, the osteometal complex, and this is the ethmoid bulla which drains to the middle ethmoid sinus. Opening of sphenoid sinus drains into the superior meatus. This is the opening of nasolacrimal duct. Now what is valves of Husner? What is the valve of Husner? Husner, what do you call it? Any guess? No, Cordell's test is a different one. It is a test for nasal valve, nasal patency. I am not talking about test. I am talking about valve. Duct valve opening is thickened and is called a valve of Husner. It is in the inferior meatus. Kieselbach area, Little's area, anastomosis. Little bit. Mnemonic is form, that is facial artery. Little's area is the Kieselbach plexus is there. The plexus is formed by facial artery, by superior labial branch, ophthalmic artery, anterior ethmoidal branch, maxillary artery by greater palatine branch, and sphenopalatine branch of maxillary artery. These are the components of the Kieselbach plexus. The maxillary sinus opens into middle meatus at the level of hiatus semilunaris, bulla ethmoidalis, infundibulum, none of the above. Infundibulum. Infundibulum is nothing but funnel. So the maxillary sinus opens into that funnel so that it will get drained into the nose. Infundibulum. This is the infundibulum. This is the infundibulum. This funnel shaped is called infundibulum. Again, this is the another diagrammatic representation where this area is called infundibulum. Which of the following is not a complication of sinusitis? Cavernous sinus thrombosis, nasal pharyngitis, preseptal cellulitis, osteomyelitis. Which of the following is not a complication of sinusitis? Any guess? Why? Nasal pharyngitis, hair bearing area, usually it is seen limited to the anterior part of the nose. Sinus of Highmore, so this should be easy. Sinus of Highmore, maxillary, also known as antrum of Highmore, largest paranasal sinus, almost with a capacity of 15 ml, and it is pyramidal in shape. apex directed to the zygomatic process. Howarth procedure is related to external frontonasal ethmoidectomy, endoscopic sinus surgery, frontal sinus trephine, maxillary antrostomy. Howarth procedure. Any idea? Endoscopic sinus surgery you can rule out. Maxillary antrostomy, what do you call that procedure? Okay, we'll come to that later. Answer is external frontonasal ethmoidectomy. There are two varieties of ethmoidectomy. Frontonasal ethmoidectomies. One is internal, which is done through the endoscope, and then the direct done in recurrent obstructive nasal polyposis. Antral route gives good visualization of orbital floor. Uses Cadwell-Lakh incision. Internal frontonasal ethmoidectomy may be used for conditions in which orbital floor has to be removed, like thyroid orbitopathy, to decompress the orbit. External frontonasal ethmoidectomy, it is preferred conditions like nasal polyposis, carcinoma, ethmoiditis, leak of CSF at frontoethmoid region, where access through the nose is very difficult, and when the lateral wall of the roof of the frontal sinus is involved in the leakage, you can do external frontoethmoidectomy. It's called Lynch-Howarth procedure, and the incision is also called a Lynch-Howarth incision. And Patterson transorbital procedure is another approach to frontonasal ethmoidectomy. And transantral Jensen-Hargan procedure is transantral through the Cadwell-Lakh approach, maxillary sinus antrostomy. You approach through the orbit into the frontal sinus. That is called Jensen-Hargan procedure. And Lynch-Howarth procedure is external frontoethmoidectomy. Pott's puffy tumor is related to, oh, it's very common bit, I believe. So chronic frontal sinusitis is the answer. This is the Pott's puffy tumor. So it is due to the chronic frontal sinusitis where the bony wall of the frontal sinus get involved, and it can cause osteomyelitis of the frontal sinus bone and leads to Pott's puffy tumor. Imaging study of choice for paranasal sinuses is X-ray PNS, CT scan, ultrasonography, PET scan. CT scan, it gives you complete, in all sections you can see the sinuses. I mean, throughout entire sinuses can be seen, because in X-rays it's only a two-dimensional.